again. But before starting the session, I would like to tell you all my compassion after this coward terrorist attack against this maternity. And congratulations to all of you from FMIC for this fantastic orthopedic and vascular surgery for this poor neonate. So the session of COVID-19 will have 4 parts. And today is the part 1, pathophysiology of the SARS-CoV-2, the virus which is responsible of the disease, with contamination, contagiousness, and protection. I know that for protective measures, Aline Perret has still made some presentations, so I will not say, I'm not going to say too much about this. The coronavirus family is a broad family of RNA virus involving several species of mammals, including humans, birds, and fishes. They are usually species specific and they are well known in veterinary medicine, poultry, cattle, and so on. In human, there is also many species, one indicating an ancient adaptation to human is the seasonal benign H-CoV, H for human. The disease it promotes is made of digestive and respiratory disorders. It's a benign pathology and it occurs mainly in children. Recently appears a beta group with SARS-CoV-1, MERS-CoV, and now SARS-CoV-2, which are promoting potentially more severe disease. This virus at first were responsible of zoonosis. And with a species jump, it's now an emerging infection in humans. We have to know that 65% of emerging infections are coming from zoonosis. The natural reservoir of the beta coronavirus is the bat. And the virus need an intermediate host. It was a pan-civet for the SARS-CoV-1, MERS, for the MERS-CoV it was the camelids, and for the SARS-CoV-2, it seems it is the pangolins. These species jump were possible due to a high level of early adaptive mutation. So we had this pandemic development in humans. But don't forget the balance between pathogenicity and transmissibility. If the virus is too much pathogen, it cannot spread. It's a spillover because it will kill everybody, and so no possibility of transmissibility. The virus, it just tries to survive, and for surviving, he has to spread worldwide. This applies for many other viruses which did not survive because there were too more pathogen and kill everybody in a small place. Around the world, there is a high level of genetic homogeneity of the virus with little variation at this time. So SARS-CoV-2 shares 67 to 80% of genetic identity with the SARS-CoV-1. Not a lot of identity with the MERS-CoV, but 96% of identity with a virus found in a bat, and 99% of identity with the genome of a coronavirus identified in pangolins. The receptors of these two viruses, SARS-CoV-1 and SARS-CoV-2, is ACE2. ACE2 is angiotensin II converting enzyme. Great presence in lungs, but also in heart, gut, liver, kidney, and vascular endothelium. And there's also a great identity between ACE2 in many species, including human. So it could facilitate the interspecies transmission. In the pathophysiology of the virus, we have the role of the virus itself with hyperstimulation of antiviral cytokine interferon. It's also a role of ACO2 directly, and there's a dysregulation of the immune system with a decrease of adaptive immunity and exacerbation of innate immune system. So it leads to hyperinflammation, and it can lead to the cytokine storm syndrome. With this COVID-19, it's now the third emergence of a coronavirus-related disease within these last 20 years. The first one was the SARS for South Asia respiratory syndrome, which occurs in 2003-2004, very limited for the countries, only 26. After that, the MERS for Middle East respiratory disease from 2012 to date, because actually there are some seasonal epidemic. Very few countries, 27. And since the end of 2019 to date, this new one, COVID-19, with a high spread, because actually 188 countries are reached by the virus. What is the spread of the SARS-CoV-2? The R0, it means the basic reproduction number, is estimated to be between 2.2 to 2.7. It means that one infected human can infect 2.2 to 2.7 other people. Some modelization shows that maybe it could be possible to have a R0 up to 5.7. So you see high contagiousness and rapid spread. The transmission is made by droplets. The flush droplets, which origin is the nose, throat, mouth, and the dispersion of the viral particles is 1 meter or even 2 meters. Other droplets, droplet nuclei, also called aerosols, which origin are the lungs, and the dispersion is possible up to several meters. After that, you have the transmission by hands, your hands, which have contacts with surfaces soiled by the sedimented virus. And after that, the hands touch your face, nose, mouth, eyes, and it's a fantastic direct access for the virus to the respiratory airway. So if you are speaking, coughing, or sneezing, the infectious exhaled air is diluted in the air, and the droplet, they will fall under gravity, and the large and small droplets travel different distance depending on the size, of course. If the smaller droplets stay a longer time in the air, the larger droplets will fall on surfaces. Here they can dry, but activities like, for example, bed making can eject these particles back into the air in aerosol. What is the stability of this SARS-CoV-2 in aerosols and on surfaces? There is a lot of studies with sometimes different results, because there's concern of methodology due to the inoculum size, the condition of temperature, of humidity. So if everybody agrees to say that the stability of the virus in aerosols in the air is approximately only 3 hours. For the other surfaces, you can see it's between 4 hours to several days. These data should be treated with caution. It's a result, there are results of PCR, but positive PCR is not correlated with viral transmissibility. The PCR can be positive while live virus is not detected by culture. It's the same, for example, if you take in a cemetery somebody who died several centuries before, okay, he's died. But with PCR, we can find DNA or RNA, but he's died. Before discussing the high-risk procedures and the protective measure, we have to rule out all these crazy fake news. First, for the transmission, no, 5G does not spread the virus. No, mosquitoes do not transmit the virus, nor water and food. No, the climate does not interfere. During the same time, we have epidemic in North Hemisphere and in South Hemisphere. It was not the same seasons. For the prevention and treatment, no, drinking alcohol does not protect. And I remember you that it killed many Iranian people who were trying to make alcohol. Sun or UV radiation does not protect. Can burn you, but not protection. Sesame oil or essential oils do not protect. A very hot bath does not protect. Garlic, hot tea do not protect you and do not treat you. Influenza or pneumococcal vaccine, they don't protect. Influenza is really not the same family of virus, and pneumococcus is a bacteria. Spraying the body with 90% alcohol or chlorine is not effective, and it's very dangerous. Nor inhalation or injection of disinfectant. It's very dangerous. Since the last speaking of Donald Trump about the possibility of injection of a disinfectant, there is in USA a huge increase of intoxication and hospitalization due to inhalation or ingestion of disinfectant. But so crazy ideas spring up every day. There's many procedures which have a high risk of contamination for the healthcare workers. It's mainly, of course, intubation, weaning trials with T-tubes, extubation, tracheal suctioning, chest physiotherapy, non-invasive ventilation, high-flow oxygen therapy, mobilization, prone positioning with the risk of accidental ventilator disconnecting, bed making, patient wash, ENT, and ACE care is due to the aerosolization of viral particles. So for the prevention, protection of healthcare worker, it's a precaution, droplets and contact precaution. Standard precaution, airborne precaution, contact precaution. I will not speak a lot about that because Aline Perret made some session about it. I just want to remember you that it's based on personal protective equipment and hydroalcoholic solution. Gown, mask, goggles or face shield, surgical cap, overshoes, gloves. For everybody, doctors, all the doctors, the big ones, the chief, the senior, the small student, all the nurses and the cleaner. Do not forget the cleaner. To wear this protective equipment, you must have a training. The dressing is not difficult. Why it is done, of course, at the entrance to the COVID unit or to the COVID patient room, we have to start by making hand friction with hydroalcoholic solution. You put the gown, the mask, eye protection, cap, overshoes, other hydroalcoholic solution, and eventually the gloves. Do not touch your face once having put on your gloves. For the type of mask, there is two kinds. The mask FFP2 or N95, which must be worn if aerosol risk. So tracheal suctioning, intubation, weaning test, mobilization, or transfer because of the risk of ventilator disconnection. For intubation, protective visor could be very useful. For the other care, with no aerosol risk, a surgical mask is sufficient. The most dangerous, I will say, for the risk of contamination is undressing. Undressing because we have to simultaneously remove gown and gloves all together, remove gown from behind and roll inside out. It's really not easy. And between every removing of PPE, do not forget hydroalcoholic solution. After the gown and gloves, it's the caps and the overshoes. Eye protection and mask are at least removed outside the box or the room. Then do not forget hand friction with hydroalcoholic solution. This undressing is really risky, so it means that everybody must have correct training for the wearing of this PPE. Other precautions, well, there are, I'm sure, department protocols for cleaning, disinfecting, decontamination of the eye protection where they are not single use, for other reusable materials, for floor and surface cleaning. I just want to tell you that if you disinfect eye protection goggles, for example, with bleach, liquid chlorine, be careful, rinse a lot because it could be dangerous for your eyes. For the floor and surfaces cleaning, it's recommended to wait 3 hours between aerosol generating procedures and biocleaning. We have to wait the sedimentation on the surfaces of the viral particles. For linen, excreta, and waste disposable, we have to put them in special bags. And for the patient, of course, if he's not intubated, he has to wear a regular surgical mask to avoid, when he's taking new aerosol. For the room ventilation, everybody said that at best it's good to have negative pressure. Okay, with negative pressure, you will not excrete the virus out of the room. But with this negative pressure, for example, you can have an entry of other pathogen into the room, and especially if there is dust out of the room, the dust can come inside, and with the dust you have a lot of fungi, especially aspergillus. Maybe it's why we have so many fungal co-infection in severe and critic COVID patients. Sure, no positive pressure. If you have a positive pressure, you will spread out of the room the virus. If you don't, have no possibility to do negative pressure or I don't know what, well, no problem, equal pressure. And it's very important to ventilate the room by opening the windows, very simply. Just one word about the efficacy of disinfectant. It's valid for all surfaces, all reusable materials, but with some products be concerned by the toxicity and so the importance of rinse. You can see that the best activity It's dark green. The best activity is chlorine against virus. A good activity with peracetic acid, okay. And you will see that ethanol alcohol at a very intermediate activity, very intermediate, and hydrogen peroxide has no activity. So it's really the chlorine which has the best activities for cleaning the surfaces or other materials to eradicate the virus. What about the contamination of healthcare workers? For example, this graph, the contamination in assistance publique hospitals in Paris. Here in blue, we have the number of admission of patients, not only in ICU, but in the hospital. And in red, the contamination of healthcare workers, doctors and nurses. You can see that at the beginning of the invasion of patients, I will say, there was a lot of contamination of healthcare workers because they were not well trained about how to put the PPE. And progressively, this rate of contamination decreased. We consider actually that the contamination rate of healthcare workers in APHP is 4.8%. And for example, in my hospital, Georges Pompidou Hospital, during March, for an ICU of 50 beds, there was no healthcare worker contamination. At the beginning of April, during the first 10 days of April, there was one contamination of a nurse, and it was quite sure that the contamination was due to a patient, was made into the hospital. For the other patient from assistance publique, we do not know exactly where was the contamination. Maybe it was in the hospital with patient, but maybe it could be outside. In China, where the epidemic was a little bit denied at the beginning, they report a contamination rate of 3.8 healthcare workers. In Italy, there is two retrospective studies, very, very interesting. For example, in the south of Italy, in Sardinia, where there was a lack of PPE, but a huge lack, no PPE, no PPE. No PPE for taking care of this patient, 40% contamination of healthcare workers. In Lombardia, they had PPE, but there was really overwhelmed with a huge influx of patients, and so it was difficult to act, and the contamination was also very high, 14%. This contamination, so it's important to wear PPE to protect the healthcare worker against the infected patient. But it's also important to wear this PPE to protect the non-infected patients. Maybe you can have the COVID with a pre-symptomatic or asymptomatic form. So you have to protect this patient also. Sometimes to prevent family contamination, but also to avoid home contamination, some relocation of nurses and doctors was done, especially in France, or also in Senegal, in the cardiac surgery center, the children's houses, the house was a nurse accommodation during some weeks. If you have some concerns about the family when you are coming back home, well, it's not so difficult for the hand hygiene. Water and soap are efficient. Home surface cleaning, Okay, but the risk with surfaces is not so important. Social distancing, I agree with you, is a difficult situation in family. So it's why for Africa, for example, and in France, it's why there was this possibilities of relocation of nurses and doctors. For the biological test, well, if the samplings are with high risk of contamination, such as respiratory sample and so on, or swab for PCR, they need a triple packaging. Rigid is better, or failing that, flexible with absorbent paper inside. If there is no or very low risk of contamination, the transplantation and the packaging of this sample is made according to conventional procedures. In the lab, no need for decontamination the container. Only use, well, standard precaution. It means at first gloves. But if samples are with high risk of contamination, you must have a lab, we said BCL, DSL2. It means that the laboratory technician has to wear PPE. And for bacteriology and so on, you must have a hood with negative pressure, regardless the performance test. Blood donation. Blood donation is not authorized if the patient, the donor, have influenza-like illness, because it could be COVID-19. But usually we never take blood when a donor has fever, cough, and so on. So it's not, it's usually eliminated. We have to wait 28 days after the healing from COVID-19, after the symptom, mainly fever and chills, are resolved. I said mainly fever and chills because, for example, the cough can persist up to 3 months after the healing from COVID-19. So it's not necessary to wait 3 months if somebody wants to make a blood donation. If a potential donor has had a contact within the prior 15 days with a suspect of confirmed COVID case, he cannot donate his blood. Why this number of days, 15 and 28 days? It's due to the PCR kinetics, and everybody knows now that this PCR could be positive up to day 21, day 28. There is no viremia except in very few severe critic patients. And of course, these patients are absolutely unable to go and give and donate their blood. They are in ICU, intubated, maybe in prone position and so on, very critic, so no problem. So in conclusion, when is it going to happen, this epidemic plateau? Well, I'm not sure that it will be soon. When you see the logarithmic slope for Afghanistan, even Bangladesh and Pakistan, the slope is relatively steep. In Iran, your neighbor, I think that now they have this plateau. But for Afghanistan, not yet. When this plateau will be reached, after that, will there be a second wave? Because you have some confinement measures, but we cannot live always with these measures because for the family, for everybody, it's not very easy. And for the economy of the countries, it's absolutely terrible. So will there be a second wave? I think that yes, it will be a second wave. Will this second wave be so important that the first one? I'm not sure. As I tell you at the beginning, the balance between the pathogenicity and the transmissibility. The virus, he wants to survive, so he wants to spread, so he don't want to kill everybody. I thank you for your attention. Do you have some question?
Dr. Seth, please.
Okay, is there any efficacy of hydroxychloroquine on SARS-CoV-2?
Well, I will speak in the fourth part of this session. I will speak about the antiviral treatment and about hydroxychloroquine. You know, it's difficult to say that there is an efficacy or not, because all the studies, all the trials actually published, they were published, it's preprint trials. The methodology was really very bad. For example, when they compare 50 patients with 500 patients, it cannot be a good trial. And unfortunately, in Europe, they began, I don't understand why, they began very, very, very late correct trials with good methodology. They just began these correct trials only at the beginning of May. So it's too early to have some conclusion. But there is, you have to do what you think is good for your patient. If you think it's a good option, no problem, no problem. But be careful with side effects.
Yes, thank you.
What about the efficacy of herbal drug?
The
Herbal.
herbal. Well, for herbal, I only know in Madagascar the Artemisia infusion, but herbal plant. Yes, you know, with the Artemisia, for example, in Madagascar, everybody knows that from this plant, they extract the artemisinin, which is a very good drug against malaria. So herbal plant, why not? But be careful, you know, because sometimes herbal plants, they have a lot of interaction with other drugs you can give to your patient. I know that some trials are ongoing, but I cannot speak exactly about the efficacy or not of these herbal plants. Herbal medicine.
Another question, what about the cases with 19 in a newborn and in children? Do you have some cases?
Yes, I will speak about that in the next session, but I can tell you some more. For the moment, there is no vertical transmission at this date. No vertical transmission. There is some cases with COVID disease in neonates, but usually they are very benign. They said that 98% of benign disease and 1% of severe disease, 1% of critical disease. The last statistic I have. And like for the other patients, the symptoms are very various, and usually, maybe sometimes it could be respiratory disease, but usually it's digestive symptoms, where they don't want to eat and so on. And for the breastfeeding, I know that in China it was forbidden, but in other countries it's allowed. But the mother has to wear a mask, surgical mask.
Thank you.
Are the radiologic finding in COVID-19?
I will speak about that for the next topic. But they are very characteristic. At the beginning, you have glass GG1.
Ground glass opacities.
Yes, yes. And after that, you have alveolar consolidation in the second, if the disease has evolution to the critic phase. I will speak of that for the last session because it's very important to make the differentiation between the two stages of the disease. There is also three stages of the disease. And for example, lung echography could be very, very useful, especially at the beginning.
Yeah. Dr. Catherine, I have one question. Could you share any data about the survival rates of intubated patients? How many, hello?
Yes.
How many patients survive among the intubated patients in ICU?
The mortality in ICU is relatively high, especially if the patients are older than 65 years. The risk factor, I will speak about that in the next session, but the risk factor of death, they are related to age, to comorbidities, and the use of prior non-steroidal drug, anti-inflammatory drugs. For example, in Nancy, in east of France, there were the doctor and the nurse in ICU were surprised because there were young people and they were very sportive, sportmen, doing a lot of sport. But this marathon, triathlon, and so on, running, race. But these sportmen, I know them, when they have some pain, they don't know acetaminophen, they only use non-steroid anti-inflammatory drugs. And so this impregnation of non-steroid anti-inflammatory drugs made that when they were reached by the COVID, they were in ICU in a critic forms. But the mortality is 65% in ICU. For the patients who are in ICU, the mortality is 65% for patients more than 60 years old, and is 35% for patients less than 60 years.
And one question more, have we seen in some reports, in some hospitals, they use one ventilator for several patients?
No, never do that.
Yeah, it is not effective, I think, yeah?
No, never do that, never do that.
Because it is sometimes very difficult to keep saturation in normal range even with one ventilator for one patient.
Yeah, never do that. And you know, now, you will see that next session, the pathophysiology of the hypoxemia is better understand. And now we know that at the beginning, it's better not to intubate. It's better not to intubate, or if you intubate, no high PEEP, no small tidal volume, and so on. It's a very specific phase of the disease, and it's really better not to ventilate.
In some research paper mentioned that the mechanism for hypoxemia is not related to the lungs, and it is some disruption between hemoglobin oxygen distribution to the hemoglobin and availability.
No. Yes, I read this paper. No, there has no fundament. No foundation. It's not a problem of hemoglobin. It's really a problem of ACE2 receptor. With dysregulation of the pulmonary perfusion, and it's why prone positioning is so efficacious, so efficient. It's a problem of dysregulation of pulmonary perfusion. No problem with hemoglobin. I read this paper. No.
Thank you, Dr. Catherine. My questions finished.
Please.
Any other question, please? Adil?
I have a question.
Catherine,
Yeah.
Azim from I is asking, what is your opinion about the rapid tests as well as the level of IgG and IgM? It's helpful for putting the diagnosis?
The rapid test for PCR?
No, for IgM and IgG.
The rapid test for serology.
Yeah.
Yes, for serology. Well, it's not possible to make the diagnosis of this disease at the beginning because you have to wait between 5 and 7 days to have some antibodies. PCR plus antibodies, yes, it's a good mean to have a diagnosis, but after the first week. Be careful, the rapid test has not a very good sensibility like the PCR.
Okay. There is another question, Catherine. What about the rate of reinfection to COVID-19?
At this date, there is no reactivation, no reinfection. I told you that sometimes the cause can persist up to 3 months. It's not a reinfection. And the problem is the very low sensibility of the PCR. And sometimes you have negative PCR. The first one is negative, the second one is negative, the third one is negative, and 10 days or 12 days after, the fourth one is eventually positive. It's due to the lack of sensibility of the PCR. It's not reactivation or reinfection. At the date, no.
Thank you.
Thank you.
Dr. Romana, do you have a question?
Assalamu alaikum. Yes, I have a question. What if they didn't do intubation for the patient? How they treat?
How they do? Well, at the beginning, non-invasive ventilation was really not recommended because of the risk of aerosol. But if the efficiency of the mask is well done, it's a good option. Of course, you have to watch your patient very carefully, because if there is a degradation, the degradation can arrive in really a few minutes, So we have to be very cautious about that. Of course, there's some patients who have to be intubated, but at the last moment.
Okay,
and
thank
you have
you.
also oxygen high flow. It's a good thing also.
And how to keep the ventilation with the low tidal volume, or what will be the PEEP and respiratory rate and these things?
Respiratory rate, it's 20 or 22, I don't know. For the tidal volume and for the PEEP, you will see that for the next session, or the third session, I think. It is very important to understand the mechanism of the hypoxemia. In the first stage, you have a dysregulation of pulmonary perfusion with hyperventilation of non-perfused areas. So ratio ventilation flow very low, and in such cases, there is really no interest to have high PEEP. And the compliance is high. If the compliance is high, you give a normal volume.
Okay, thank you. Thanks a lot.
Okay, thank you, Dr. Catherine. I have a question. Is there any available data about the usage of hydroxychloroquine or prophylactic usage or not?
Actually, there is in Assistance Publique, Paris, there is a trial of use of hydroxychloroquine versus azithromycin versus placebo, nothing, for healthcare worker for prophylaxis. But we don't have the result.
Is what effective or not?
I don't know. We don't have the result because the trial began 3 weeks ago.
Yeah, yeah. Thank
you. Dr. Catherine, can you hear me?
Yes, yes.
There is a recent report of pediatric multisystemic inflammatory syndrome or Kawasaki-like disease in children.
Yes.
Did you face any patient like this, and how you treat these patients?
Well, the treatment of Kawasaki syndrome, it's IVIG.
Also, same as this.
Same as Kawasaki syndrome, yes. We said pseudo Kawasaki syndrome because, you know, usually the Kawasaki syndrome, you know that better than me, because you are more pediatrician than me. This Kawasaki syndrome is usually a post-infectious syndrome, post-infectious complication. It occurs many days after the healing of an infectious disease. And here, for the patient we had in Necker Hospital, for example, sometimes the infection was not totally finished. But be careful because they said PCR were positive. But we know that PCR could be positive without a live virus. But the treatment is like usual, IVIG, high dose.
How common is this for children? How common? How is there any percentage of?
Any percentage? Well, it's difficult because to give a percentage because I know that in France there is 150 or 122, I don't remember exactly, children who were hospitalized for such a syndrome. It's difficult to give you a rate because so few children are tested with PCR. There is a lot of atypic forms, asymptomatic forms, so it's difficult to say.
Thank you.
But one thing is true, with COVID-19, sorry, maybe there is more Kawasaki syndrome than for the other viral infectious disease.
Thank you.
Thank you, Katin. Yes. Katin, there is another question from ICU. What do you think after fighting the infection? The body could be at the back level of the immunity. After how many months, days, weeks after COVID-19?
You can repeat the question?
After
after subsided or resolved the symptoms of the COVID-19, up to how much the patient or survival has the immunity against COVID-19, or how long?
The immunity?
Yes.
The immunity, hey, that is a question. It's a very good question. We know that the antibodies are protective, but we don't know, actually, we don't know if this protection is for 1 year or many years. For example, for the SARS epidemic or the MERS epidemic, we know that the immunity due relative with the disease can be up to 3 years for the SARS. And for the MERS, there are some cases, the immunity is up to 7 years.
After the infection has been subsidized, can we count individual as a
is a carrier.
As a carrier
for another person.
for another patient.
I'm sorry, it was a little bit noisy, so I did not understand the question.
Catherine, after someone is subsidized from the infection, can we count him as a carrier or no?
After what? After?
And somebody is
After resolved all symptoms of COVID-19, subsided IgM, IgG, is we accept that one as a carrier or not for COVID-19?
If we accept to take...
Catherine, la question, c'est si quelqu'un, par exemple, après il a passé le COVID-19,
Oui.
est-ce que celui-là, cette personne, on pourra le compter as quelqu'un qui transmet la maladie?
Ben non, s'il est guéri. No, of course not. It is, you know, when the PCR is negative, there is no risk of transmission. And it depends also, it also depends on the inoculum size in the PCR. If it is very low, there is no risk of transmission. And I repeat, PCR positive doesn't mean that the virus is a live virus.
Okay, thank you.
Thank you.